We have now finished the bulk of the endocrinology material, and the final topic for this lecture will be some of the drugs used to treat endocrine diseases. The treatment of diabetes mellitus is a massive topic with large amounts of pharmacology as well as randomized controlled trials, and it is also a topic that you hear about in the media very frequently. We'll touch on the high-yield facts contained in this table. The basic strategy for type 1 diabetes is to replace the insulin that the patients cannot produce and institute a low-sugar diet. For type 2 diabetes mellitus, patients generally start with efforts at dietary modification and exercise with the goal of weight loss. Sometimes pharmacological intervention is initiated right at diagnosis, and other times it is started later in the disease course. But the two general drug categories for type 2 diabetes mellitus are oral hypoglycemic agents and insulin replacement. Let's begin with insulin. Insulin is always injected because as a protein molecule, it would be degraded in the GI tract. Of course, the job of insulin and the insulin analogs is to bind to the insulin receptor, which leads to all the expected downstream actions: glucose storage as glycogen in the liver, glycogen and protein synthesis in muscle, as well as potassium uptake, and triglyceride storage in fat. There are different insulin options from rapid to long-acting, such as Lispro, Aspart, and others. The major concern with using insulin is the high frequency of hypoglycemia. This occurs when too much insulin is given, or when insulin is given but no food is eaten. Whereas hyperglycemia is generally deleterious over the long term, hypoglycemia is almost always acutely dangerous. Perhaps this is why we only have one hormone that lowers blood glucose, namely insulin, but several that raise blood glucose, such as glucagon, growth hormone, cortisol, and epinephrine. The first class of oral hypoglycemics listed are the sulfonylureas. There are two generations of these drugs, the first rarely used now and the second quite common. The latter includes glyburide, glimepiride, and glipizide. Sulfonylureas act on the beta cells of the pancreas to stimulate insulin release. The idea is that you can increase the output of endogenous insulin instead of having the patient take regular shots of insulin. The mechanism involves closing a potassium channel, which causes membrane depolarization and opens voltage-sensitive calcium channels. Influx of calcium ions triggers exocytosis of insulin. Of course, this can only be used in type 2 diabetes mellitus because you need functional beta cells. Because you are forcing more insulin into the bloodstream, you can have the same side effect as when you give exogenous insulin, namely hypoglycemia. The next drug is metformin, which is in the biguanide class. This drug is commonly prescribed, and yet the exact mechanism of action remains unknown. We do know that patients taking metformin show decreased gluconeogenesis, increased glycolysis, and increased peripheral glucose uptake, which are all things we want to happen in the setting of diabetes mellitus. The major side effect to be aware of is lactic acidosis, and therefore the drug is contraindicated in renal failure. Importantly, metformin does not require beta cell function for efficacy, so it can be used in type 1 diabetics as well. The glitazones, or thiazolidindiones, have received a lot of press recently for concerns of cardiovascular toxicity as well as the process for conducting their clinical trials. They act to increase insulin sensitivity in peripheral tissues by binding to the PPAR gamma nuclear transcription regulator. Other side effects include weight gain, edema, and hepatotoxicity. The alpha-glucosidase inhibitors are taken at the beginning of meals, and they act by blocking the alpha-glucosidase enzyme on the intestinal brush border. This delays sugar hydrolysis and glucose absorption, and therefore decreases postprandial hyperglycemia. However, many patients experience GI disturbance with these drugs, so they are not heavily prescribed. The last two drugs to mention here are actually injected. Pramlintide is an analog of the protein amylin, which is actually secreted in normal people along with insulin by beta cells. The main function of pramlintide is to decrease glucagon secretion, though it also acts to delay gastric emptying and promote satiety. It is associated with hypoglycemia, nausea, and diarrhea. Exenatide is a glucagon-like protein 1 analog, and it acts to boost insulin release and reduce glucagon release. It also can cause nausea and vomiting, and occasionally patients develop pancreatitis. Obviously, this requires some residual beta cell function, so it doesn't work for type 1 diabetes. This concludes our list of diabetes drugs. We'll wrap up with 5 other high-yield endocrine drug categories. Propylthiouracil, or PTU, and methimazole are drugs that have been used in the treatment of hyperthyroidism. They act to inhibit organification of iodide and synthesis of thyroid hormone, and PTU also decreases the peripheral conversion of T4 to T3. Adverse effects of both drugs include skin rash, agranulocytosis, and aplastic anemia. Methimazole has potential teratogenic effects and therefore should not be used in the first trimester of pregnancy. PTU has recently been found to cause idiosyncratic hepatotoxicity and should only be used in rare circumstances such as life-threatening thyrotoxicosis or when methimazole, surgery, and radiation treatment are contraindicated. Levothyroxine and triiodothyronine are synthetic versions of thyroid hormone given primarily to patients with hypothyroidism. Toxicities are similar to the clinical symptoms of hyperthyroidism, which include tachycardia, heat intolerance, tremors, and arrhythmias. On the boards, hyperthyroidism symptoms with no other apparent cause can sometimes be caused by surreptitious use of these drugs for weight loss. Here, I will briefly mention some drugs that affect the hypothalamic pituitary axis. Growth hormone, which can be given to patients with growth hormone deficiency or Turner syndrome. Octreotide, a somatostatin analog that is useful in acromegaly, carcinoid syndrome, gastrinoma, and glucagonoma. Oxytocin, which you will hear more about in the reproductive lectures. And synthetic ADH, or desmopressin, which is given for central diabetes insipidus. Demeclocycline is actually one of the tetracycline antibiotics, but a known side effect of the drug is to antagonize ADH. This makes it clinically useful in the treatment of syndrome of inappropriate ADH, or SIADH, since it can block some of the excess hormone. The toxicities include nephrogenic diabetes insipidus, which is related directly to the desired effect, and also photosensitivity and abnormalities of bone and teeth, which are common to all tetracycline drugs. Lastly, the glucocorticoids. There are many different steroids and all share a similar mechanism. They inhibit phospholipase A2 and the expression of COX-2, which decreases the production of leukotrienes and prostaglandins. They are used in many different scenarios, but some you should be familiar with are Addison's disease, inflammatory conditions, situations in which immunosuppression is desired, and asthma. The major toxicity is an iatrogenic Cushing's syndrome, which is dose-dependent and consists of the typical Cushing features: buffalo hump, moon facies, truncal obesity, muscle wasting, thin skin, easy bruisability, osteoporosis, adrenocorticoatrophy, peptic ulcers, and potentially diabetes. If treatment is suddenly stopped, adrenal insufficiency may ensue because the gland has not had time to restart endogenous production.